Again, thank you very much to the Philippine Academy of Ophthalmology and, of course, to my very own Philippine Cornea Society for making this possible. And, of course, to Santen for sponsoring this event. Okay, mic check. Everything is okay? Is everything okay? Am I on?
Yes, we can hear you.
Is my slide on?
Yes, slides okay.
Okay. So as mentioned earlier, this will be a three-part lecture. So as everybody knows, the field of corneal external disease is quite huge. So it's impossible to finish the topic in just 1 hour or 1.5 hours. So I decided to divide this into 3 sessions. I think we came up. The subject matter itself, it's nothing new. It's just basically a review. But since we are now since there's no end to the COVID-19 pandemic, despite the announcement of our very dear Secretary of Health, it seems that we have to deal with the remote diagnosis and management of some of our patients. So thus the objective of this lecture is to provide pointers on how to diagnose and manage common diseases of the eyelid, conjunctiva, cornea, and ocular surface remotely by means of teleophthalmology. And it's also to inform what external eye disease conditions that will require face-to-face consultation. So in short, I'll be giving you some tips on the how you can at least get to the diagnosis as close as possible without directly examining the patients, which is it's not possible when you do a telemedicine. So, of course, there are limitations to teleophthalmology. Obviously, you cannot use a slit lamp, unless the patient has own slit lamp or there is an area where there is a slit lamp and it can be beamed to you, for you to be able to see the eyes up close with a magnified view. Without a slit lamp, we cannot have a magnified view. Without very bright, good lighting, we cannot get a very clear image. Even patients would they would use their phones, basically, or their laptops, or their computer cameras. They cannot really very good macro. They don't have macro lenses, to get very nice or very close up pictures of the eye. So the resolutions and the definitions of these images are quite limited. Of course, if there's no ophthalmologist there, I don't think most of our patients cannot avert their upper pupillary conjunctiva. So most cases, you will not be able to examine that. And obviously, again, you cannot check the eye pressure and check the inside of the eye and do certain tests, like fluorescent staining, use membrane staining, do corneal sensation, do tear breakup time, Schermers, and all those tests cannot be done through teleophthalmology. But despite of all of these limitations, I think we will be able to diagnose with enough information. We'll be able to diagnose as much cornea and external disease as possible and manage them adequately. Okay, so a 3-part lecture. Part 1 will be on blepharitis, meibomian gland dysfunction or jaw loom and dry eye disease and herpes zoster ophthalmicus. For part 2, we'll talk about infectious conjunctivitis, allergic conjunctivitis, VKC, GPC, contact dermatoconjunctivitis, actinic conjunctival granuloma, pinguecula, and your nodular scleritis. And part 3 will tackle infectious keratitis, granulosis, marginal keratitis, interstitial keratitis, and end up with your paddy keratitis. Okay, so let's begin. Okay, so first is blepharitis. Okay, it's a very common problem. It's a common cause of external ocular irritation, and it is quite difficult to treat effectively. So the first thing you have to do is to identify the etiology. So you have your staphylococcus, your seborrhea, and your meibomian gland dysfunction. This can also be classified as anterior blepharitis, which is staphylococcal, and your seborrheic blepharitis, and your posterior blepharitis, which will be your meibomian gland dysfunction. Technically speaking, MGD is no longer classified as a blepharitis, no, strictly, no. So it's now a category on its own, on the meibomian gland dysfunction, or MGD. Okay, so what patients would complain of early morning. So patients might contact you for teleconsult, and what do you ask? No, I mean, what will they say that will make you think this is Staph Blepharitis? So you know that the affectations at the lid margin, at the base of the lashes. So patients may complain of redness at the base of the lashes, burning sensations, especially on waking up in the morning. Okay, they have some crossing and discharge. And the age of the patient is very important. Usually, the worst diseases are those in young female in the early teens. No? So, early teen patient complaining of chronic on and off eye redness with burning sensation or crossing, especially on waking up in the morning. And there's also noticeable redness or erythema of the lid margin. Maybe you should start thinking about Staph Blepharitis. No? So, it's recurrent, chronic. Okay, and the symptoms are worse in the morning and in young female patient. Okay, those are the things that you have to ask. Okay. So of course, you try to look for lid margin erythema. No, if you're able to see the fibrin at the base of the lashes, then that will clinch your diagnosis for Staph Blepharitis. For Seborrhea, it's the opposite end of the age spectrum. Now you'll have an elderly patient complaining again of burning sensation. Okay, usually they have very greasy skin. Okay, they have oily skin and they have these flakes, not the lashes. Again, it's a chronic, recurrent condition. Okay, it's not something that is not acute. So if you have that kind of background or that kind of profile, okay, maybe then, and it's also involved the lashes, the eyebrows. So it's not only confined to the eyelashes. Even the brow will have flaking. Okay, and they might have some form of rhinophyma. Okay, so these are your seborrhea that can be that would point towards a seborrhea blepharitis. MGD, no, MGD is quite common, no, okay, but not every patient with MGD will be symptomatic. So, but the most common patients with MGD will be the elderly patients, no, from 40 and above, 40, 50, 60 and above. And then the complaint is very similar to those of dry eye disease. Okay, so in MGD, unless it's a mixed type, no, it's a pure MGD. The lashes are quite normal. Okay, you don't really see changes on the lashes. Now you basically see changes at the orifices of the meibomian glands, and that is behind the gray line. Okay, so patients will be older, as mentioned earlier, and they will complain of discomfort, burning sensation, very similar to dry eye disease. Okay, so that's the thing that you have to rule out. So when you get the patient with those complaints in that age group, and it's around the eye, then you have to think, is it MGD or is it due to dry eye? And very often they exist together. So you have to consider both conditions. Okay, so this is just a tabulation of the main difference. No? So Staph, young patients, MGD and Seborrhea elderly, location, Staph's anterior, MGD more posterior, Seborrhea anterior. What do you look for? What are the key findings? Fibrinous crust at the base of the lashes for Staph. Okay, you see or no crusting much on the MGD, oily greasy crust in patients with Seborrhea. You see ulceration of the skin at the base. That's why you get lid margin erythema. Okay, there's no skin changes in MGD and Seborrhea. No ulceration, but you get oily skin in patients with seborrheic blepharitis. On the lower palpebral conjunctiva, all three cases might show some papillae. And and then on the cornea, its Staph is the worst, has the most complication on the cornea, like your punctate keratitis, superficial punctate keratitis, marginal infiltrate, pannus formation, flected, and corneal thinning, and actual rupture, even your marginal ulcers. In MGD, it can show some inferior punctate keratitis, and pannus formation in chronic cases. Likewise in Seborrhea. Again, the staining, if you have blepharitis, usually the staining is located at the inferior third. Okay, but again, on telemedicine, you can't see that. But if you have access to a slit lamp, you can do stain, then look for inferior punctate staining. Okay, so Staph Bleph, they have it has a lot of complications or other associated diseases like orjolum, ulcerative Bleph, chronic Bleph, papillary conjunctivitis, marginal infiltrating ulcers, inferior punctate keratitis, and panosenior flectinellosis. And we'll discuss these one by one. Of course, I think one of the most common cases as my residents, they said, what is the most common cases patients would go for teleconsult, and they usually may orjolum. Why? Because it's painful. It's painful. There's a mass. It's tender. Okay, as it always, if it's painful, patients would seek consult. So you see a red mass, erythematous, and you ask the patient. It's tender. It's very acute. It can develop over just 1 or 2 days. And the patient they can take a gross picture with your phone. And I think there is this is something that you can really do actually at least diagnose remotely, okay, without need for seeing the patients. It's basically just like subconjunctival hemorrhage. It's very, very obvious. So of course, what do you say? So this is recurrent. So again, you have mostly again young patients will develop this. It's recurrent. It may not be the first time. Again, they might have in the elderly there will be lack of lid hygiene. Okay, in the younger patients, they might have oily skins, and or in some cases, they have meibomitis or chronic recurrent meibomitis, and the orjolum comes with it. Or some patients will have Staph Blepharitis and have recurrent orjolum. So the thing that really can give is to ask the patient at the very outset. It's warm, moist compress. It's very, very effective. With the first symptoms of pain and tenderness, usually they will say na pag kumukurap, masakit. And then when they touch it, it's quite painful. So when they give that warm compress at the outset on the first day, usually can resolve the condition, okay, without making it progress to an actual abscess. Okay, so if it's quite large, so when there is pointing, when there's cellulitis, okay, then or even it might lead to a preseptal cellulitis, and then you have to prescribe your systemic antibiotics. Okay, you have to apply antibiotic ointments, give pain control. Okay, lid hygiene is for aftercare. So once it resolves, then you could ask the patient to do lid hygiene. Now, if it's really pointing and it's draining, or it's really painful, or if it's draining and it seems like it's not completely draining, then you might have to ask the patient come in and schedule them for an incision and drainage, or even an incision and curettage. Okay, so intralesional steroids reserved for those scars for when they have turned into chelation, or when the orjolum has resolved and there is this capsule, this hard capsule that remains. Then you can give intralesional steroids. But for teleophthalmology, I think really warm compress will be your first line, okay, and then prescribe your systemic antibiotics and ointments if there is signs of cellulitis and a large abscess. Okay, and then there's a large abscess, you really have to ask the patient to come in to drain the abscess, or else it will take a while for the condition to resolve. Okay. Okay, so just more pictures of Staph Blepharitis. So you have the benefit of a slit lamp. You look for the collarettes. You don't have to see collarettes all the time. Okay, so if you see them, then it's well and good. Okay, these are just dried fibrin that are stuck to the lashes, at the base of the lashes, on the skin, and as the lash grows out, it follows the lash. So it's like a salbabida, so a collarette. Again, you don't have to see that to make a diagnosis of Bleph, of Staph Bleph. In some cases, maybe a gross picture. If the patient sends you a gross picture like this, then you can definitely diagnose it as staphylococcus blepharitis. Well, this is quite very obvious now. Okay, so it's not very, very common. Actually, this to become like this condition, it's quite rare. But if you see this, definitely systemic antibiotic should be given, chronic at least the full course, and a chronic treatment with your antibiotic ointments, on the lid margin. Okay, these are just chronic changes, when when they had this way before, and then they come in to you with loss of lashes, trichiasis, short stunted lashes, so those are signs of chronic staph bleph, poliosis, madarosis, and all this ankylosis. Then these are again signs of chronic staph. So it may not be an active disease. Patient may not have a complaint. This is just might just be an incidental finding. You don't really have to treat this because these are structural changes due to the scarring now on the lid at the base of the lid margin itself. Okay, so how do you manage your ulcerative and chronic staph bleph? Again, chronic staph bleph, if it's symptomatic. If it's not symptomatic, you don't have to treat. Okay, so lid scrub is the mainstay of therapy. Okay, so you really have to keep the lid margin clean. So one way is to, I always give them commercial gel preparations because it's more convenient than soap and diluted shampoo. If they cannot get the gel, tell them just when they take a bath or when they clean their face, just use just soap up their fingers, and just rub the lashes. That's easier to do because I've noticed that if you ask them to do the shampoo and then put it on a cotton bud and put it on the lid margin, they will not do that because frankly, it's quite painful. If you do it yourself, the lid margin is very sensitive. They won't do that. So it's easier to just rub the lashes, the lid margin with soapy water when they're taking a bath. Okay, so if there is ulcerative changes on the base of the lashes, then pure antibiotic at the start 2 to 3 times a day for around 2 weeks. Okay, so and then you do not stop. So because if you just use it for 2 weeks, it resolves. When you stop, it will always come back. It's a recurrent problem. Remember, staph is right there on the skin. You cannot totally eradicate it. You're just trying to control the population of the staph there, so it doesn't cause clinical disease. So you want to, in other words, you want them to become asymptomatic staph carriers. So you have to put them on antibiotic lid scrub at bedtime probably for the next 3 months. So just to prevent a recurrence. So again, short course, 2 weeks, they will resolve, but again, continue bedtime lid margin scrubbing for the next 3 months to prevent recurrence. Okay, because it's a very, very common problem. Now, when you see significant inflammation at the lid margin, if the cornea is clear, there's no ulcerations or anything, then you can give antibiotic steroid ointment as a lid scrub instead of just a pure antibiotic. Okay, again, most important, lid scrub with ointment. If they cannot do washing, fine. If they cannot do shampoo, fine. But you cannot miss out on the ointment scrubbing. Okay, so that is the minimum that you can give for these patients. Okay, so once in a while, so they will cause redness, conjunctivitis, discharge. So probably grossly you might see this when they send a photo. Okay, lid margin changes, very, very obvious on top. Okay, and then when you pull the lower lid down, you see papillae, you see changes on the lid margin crossing all that. Again, you see this picture now. This is Staph Blepharitis. Okay, so this is Staph Blepharitis with inferior panus formation. Okay, this is quite chronic now. It doesn't occur in a day or two. This will take weeks and months to form. Okay, Flecten. Okay, in a patient, look at the lid margin. There is inflammation of the lid margin, and on that you see a large conjunctival flecten here. Okay, not very, very common. Okay, the more commons will be this thing on the limbal area, those little nodules. Okay, so you have these multiple flectens, okay, at the limbal area. Okay, so they have redness, foreign body sensation, okay, and photophobia. If they have this lesion. Okay, so again, what you don't want once there is a cornea is involved, if there is marked pain or there is decrease in vision. Okay, on a picture on an eye that looks like there is Staph Blepharitis, then they have to be seen face to face. This cannot be treated remotely, no? Because this can develop into a demetocele, it can actually rupture, no? So or it can develop into a frank bacterial keratitis, no? That will not be, again, they have to be seen on an urgent basis. Okay, so what do you do now if when you see a patient with marginal keratitis, conjunctivitis, flectanulosis, and it should be due to staph? No? So there should be staph chain, and these are this is your main diagnosis, and these are the associated findings now. So topical antibiotic steroid is very, very important. Steroid, because most of these are inflammatory, most of immune mediated. Then you have to give steroid here just 4 times a day, no, nothing more. Okay, for 1 to 2 weeks only. That's enough. No? That will be enough to suppress the inflammation, no, and make all these lesions resolve. But you cannot miss out again on the lid margin. No? So you have to treat the lid margins chronically. Okay, for the topical, just a short course is fine, 1 to 2 weeks. But the lid margins, treat it just like your regular Staph Blepharitis for 3 months. Okay, and then again, no, to prevent recurrence. Okay, I hope so. There. Okay, so I hope you have enough information, no, on the management and the diagnosis and management of your staphylococcal blepharitis and all of its complications. So we now move towards the next topic is on meibomian gland dysfunction. So very, very common. No? Actually, it's more common than your Staph Blepharitis. Okay, but it's overlooked in the cause of ocular irritation, because the findings might be very, very subtle. No? So if you don't really look closely at the meibomian gland orifices or flip the lid, look for the meibomian gland loss of acini, you might miss this condition. So what is the profile? Okay, so middle age to elderly. Okay, very rarely, you get severe MGDs in the young, or even in young adults. So it's because partly MGD is a degenerative change of the meibomian gland itself. So if patients come in burning and foreign body sensation, congestion, stickiness, and filmy, madikit, parang madikit, and parang palagi may this again filmy vision, parang may nakaharang. The vision fluctuates because of this moving film. Okay, and then sometimes they will have this stickiness or foamy discharge at the corners of the eye. So if you have this not complaint, then you start thinking about an MGD. Okay, so it can lead to a lipid tear deficiency, resulting to tear film instability, changes in the tear, increasing evaporation rate of the tears, and even changes in the osmolarity of the tears. So they go hand in hand with your dry eye disease. I don't think you can see anything by if they send you a photograph. You really need a slit lamp to be able to see all the signs of MGD, pouting plug meibomian gland orifices, turbid or inspissated secretions, decreased tear breakup time, telangiectasia lid margin, foamy tear meniscus, and your disorganized meibomian gland acini. So we might have to base mostly on the symptoms of the patient. Okay. So this is quite early. These are very, very mild disease, trying to show the early changes on the opening of the meibomian gland orifices. There's light pouting already here, and there's loss of that regularity, that regular arrangement. Okay. Here it's more pouting of the orifices of the meibomian gland, and you also now see telangiectasias on the surrounding, okay, the openings of the meibomian gland. Okay. Okay, so here, some more obvious now. Okay, so there is plugging now. Okay, your meibum cap, in some of the opening of your meibomian glands. Okay, so there's more disorganization here in this picture. There's also telangiectasias. Okay, their blood vessels are prominent now on the openings, and there's plugging and pouting of the actual pouting of the meibomian gland orifices. And this will be the foamy discharges. So that's why they call plain of filmy visions, not when they blink. So there's always this foam that goes over the tear film. So they complain of fluctuation of vision, Okay, and then if you look at the lid margin closely, now you see this foam. So this is very suggestive of the MGD. Okay, so what do you do? No? So if you suspect MGD, heat is the most is really the most important treatment that you can give. Okay, so warm compresses. Okay, followed by lid hygiene cleaning of the oil itself. So you really have to apply heat. So even those gadgets, those things that expensive gadgets, really it's really the heat that is applied. That is important on cases of MGD. So what is the easiest is really warm compresses. You can advise them to do that, and have to do it at the start probably twice a day, once in the morning, once in the evening, immediately followed by cleaning. If they don't have gels, again, they can use soap and water to just wash off the lid margin. Okay, so lubricants, so it's impossible because of the symptoms. They might have tear film instability, evaporative type of dry eye. So you give your tear substitutes. Then if you see quite a lot of, if you're very prominent telangiectasias, maybe it's a good idea to give antibiotic ointment steroid, antibiotic steroid ointment combination as a lid scrub at bedtime. Okay, we don't give topical azithromycin anymore. It was not available. So if ever in severe cases, if long-running severe cases that is recalcitrant to your very conservative management, like warm compresses, lid hygiene, and lid scrub, if these don't work, then you have to start giving them oral doxycycline 100 milligram, at least around. It start with 100 milligrams once a day for 3 months, 2 to 3 months, depending on the tolerance of the patient. But again, you have to give it long term. Okay, you cannot give it for a week. You cannot give it for 2 weeks. If you're going to start it, at least give it for the next 2 to 3 months. Okay. Well, aside from heat, the most important thing about MGD is expression of meibomian secretions, which you can't do, okay, remotely. So, but if they have to do it, if it's severe, then they have to come in, okay, and they have to express the meibomian glands, so that they get this thick, pasty, or abnormal oil meibum out of the gland itself. Okay, so they can lead to chalations because plugged meibomian glands can lead to internal orgeal loop, which can turn into chalations. Then I'm sure all of you knows how to treat chalation. So again, which you can try in patient. They cannot, if they don't want to come in for an INC, then try first with the antibiotic steroid ointment once or twice a day for a month and see if the chalation itself would shrink in its size. Okay. Seborrhea, not very common here. Okay, we usually see this in white patients, but if you do see seborrheic patients, the treatment is very, very similar. Okay, in the treatment of MGD. Okay. So as I mentioned earlier, MGD usually they go hand in hand. In our latest dry eye cross-sectional study, Philippines, our dry eye survey, okay, 60% of our dry eye patients would have changes in the meibomian gland based on meibography. So more than half. Okay, so you can actually assume, safely assume that patients with dry eye symptoms might also have MGD, or MGD patients will also have concomitant dry eye. So in the absence of all the tests, I think you can err on the side of caution by over treating. Okay, and usually the treatment is not that harmful. Okay, by providing dry eye treatment. Okay. So well, if you want to do the entire, of course, you have to do a dry eye diagnosis. You have to do all the dry eye tests. Okay. Now, institute appropriate dry eye management. Okay, so just a caution in case that in patients really with dry eye, with aqueous deficiency dry eye, with low Schermers, very, very, very narrow tear or very low tear meniscus height. Okay, let's say patients with rheumatoid arthritis, or Steven Johnson's and all that, really, really dry. If there is significant MGD, that is still inflamed, again, don't put punctal plugs yet. Treat first the MGD before putting the plugs for the treatment of the dry eye. Okay, so it should be emphasized in the general management of blepharitis. You have to emphasize that the patient, the condition is chronic and recurrent. Okay, because that is usually the problem. Some patients, they think after 1 week of treatment, okay na. Tapos after a few months, they will be back. Okay, with complaining about the same thing. So they should understand the important compliance of treatment and to do it as instructed for the prescribed duration of treatment. Okay, so compliance is important, and it's our responsibility to provide a treatment regimen that is both effective and convenient, because again, compliance is highly dependent on convenience. So if you have to look at the gauge this personality of the person. Okay, kung masinop siya, kung ma-OC siya, then you can give very, very detailed regimental treatment. Okay, but again, if the patient is not, it's a busy person, okay, it's not very, very detail-oriented, okay, then probably just give the minimum treatment that you think that they would comply. Okay, so you have to be quite flexible on this. Okay. Any questions? Do we have 13 questions? No, not yet. Okay. All right. Okay. Well, so dry eye might be a common complaint, for through teleophthalmology, because the symptoms can be very irritating. It's there every day. When the patients stay at home order, what will they do? Watch Netflix, watch YouTube. Okay, right now you're watching YouTube. Okay. And then with all this long series, and they would really have dry eye complaints. Okay, so we actually stay at home and watching TVs, watching all these series actually predisposes, or actually is a risk factor for developing dry eye. Okay, so we have PAO has been giving out a lot of advices. Okay, about the 20-20-20 rule, about that. Okay, so now if they really have the disease, they might seek consult because it becomes irritating. They have fluctuation of vision. They have quite discomfort. Then they would come in. Okay, so just an overview. There's the previous dry eye syndrome, dysfunctional tear syndrome, your case Zika. After all the past 25 years, everybody just settled on a very simple dry eye disease. So everybody calls it dry eye disease. It's simpler, it's direct to the point. It's easily understood by the layman. Okay, so this used to be a simple classification, and looking back now, a very simple lang way back in 1995 by Michael Lemp. Okay, who's at his time, he is really the guru of dry eye. So it was just tear deficient and evaporative, and all that. Okay, so you can forget about this now, but it's no longer that simple. Okay, so definitions have changed through the years. They have used 2007, and 10 years later, just 2017. Okay, telling you that it's a multifactorial problem of the ocular surface with the loss of hemostasis of the tear film, with ocular symptoms in which there is tear film stability and hyperosmolarity, and ocular surface inflammation and damage, with neurosensory abnormalities may play etiologic roles. So it's basically a quite complicated definition itself. So the ADAS, okay, came up even up to now. So there is a multifactorial Asia Dry Eye Society just focus on unstable tear film causing a variety of symptoms of visual impairment and potentially damaging the ocular surface damage. Okay, so remember, Juice Workshop, all of these, iba kasi yung people, the type of people, professionals, who did it. In Dry Eye Workshop, a lot of these were researchers, basic scientists, very, very few clinicians. So they really concentrated on the pathophysiology and the immunology and the cellular changes, okay, in dry eye. In the Asia Dry Eye Society, which started from the Japan Dry Eye Society, these are mostly clinicians. So, okay, so their definition is more clinically oriented. It's simpler, it's easier to understand. Okay, because if you follow the juice, no, you have to do so much tests, okay, to be able to get all of these, no? By looking at the eye, you cannot say what kind of what if there is surface inflammation. By just looking at the tears, you cannot say the hyperosmolarity, right? So about loss of homeostasis, no? So it's by just a clinical exam, you can't see those, no? Okay, but unstable tear film with the slit lamp and the fluorescein, then you'll be able to diagnose that. Okay, quite common. Okay, based on our community survey, it's a 23%. So now risk factors. No? So patients come in, elderly, female. Okay, they may or may not be contact lens wearer. Okay, if they have rheumatoid arthritis or connective tissue diseases, and then they have dry mouth. Okay, dry eye na yan. No? Very sure usually those with aqueous deficiency dry eye are those with autoimmune problems like rheumatoid arthritis. Although it's not very common in the Philippines or in Asia, unlike the West, they have lots of autoimmune disease, a lot of rheumatoid arthritis patients. That's why their aqueous deficiency patients are quite high. Okay, but here it's the reverse. Now we have more evaporative or your tear instability type dry eye, and not so much on the pure aqueous deficiency dry eye. But patient, you have to ask about their diseases: rheumatoid arthritis, dry mouth, dry eye, female patient, elderly. No, then you're by that profile alone, you can almost be sure that you're diagnosing dry. It's bilateral, no, in all the and with the dry eye symptoms. So they had procedures, LASIK, recurrent phacoemulsification, just in a few weeks ago. That can cause dry eye. Yeah, video display terminals. Okay, maybe we have lots of those nowadays. Topical systemic medications, now your anxiolytics, and okay, and all those neurotrophic drugs. Now they can cause suppression of tear production, chronic allergies. Again, mentioned earlier, blepharitis, MGD. Okay, the working conditions. Now all these are risk factors for development of dry eye. Okay, so look at this. So this is the current classification of dry eye disease as presented by JUICE 2017. Okay, so remember, basic in their definitions: aqueous, evaporative, and then you have the mix. No? If they have a little of this and a little of that, then it becomes your mix. Okay. Okay, we'll talk about this. So symptoms. No? So what will be their symptoms? Discomfort, irritation. No? It's a constant. It's not really pain. Okay, it's not as painful as a corneal abrasion or jaw loop. Okay, that there is this awareness. Okay, there's always constant awareness that there is something in the eye. Okay, then they might have actual foreign body sensation when they blink. Okay, they might get a gritty sensation, or they have a dry eye, again, a drying sensation. Okay, itching. Okay, a lot of patients will have itching as part of it, no? Because itching is a mild form of pain. Okay, so remember, like, diba, when your skin starts to dry, okay, you also feel an itch. Okay, so tapos when you scratch, then all these flakes, no, you have this flaking and namero na yan. Okay, so itching is caused by dry. You can have dry itching in dry eye patients. Burning and stinging sensations, mahapde, tearing. There's actually paradoxical tearing, no? Because dry become comfortable, then there's reflex tearing. They might have always this moist sensation also, okay, especially if they have MGD. Eye strain and fatigue, again, because of tear instability. There's constant trying to focus on something. Okay, they get eye strain, blurry vision, fluctuation of vision. If they have punctate keratopathy, filaments on the eye, then they will get photophobia. Sticky moist sensation, frequency of blinking, especially kung nanginan, di ba? When you get wind into your eye, you will really increase your blinking because it's very uncomfortable. Redness is not way up, okay? But if the patients if you think it's dry eye and there is redness and there is decrease in vision, those are danger signs, no? Because normally redness is not very common sign in dry eye patients, no? But if you think there's dry eye and there is redness and there is frank pain, okay, because there might be severe corneal changes or pathology, those should be seen. Because sinasabi lang nila, mahapdi lang, nakapagod yung mata, occurrent fatigue, mahapdi. Then probably, you can diagnose and treat them over the remotely. Okay. Okay, well, if they do come in, no, to see you, no, then really have to do the dry eye workup, no, on a step wise manner. Okay, so ocular exam. Okay, now if you have a means to measure osmolarity, this has to be done way ahead. Okay, so from the history pa lang, probably dry eye. Then you do a cursory exam of the eye. It's nothing obvious, no. That is what to point towards another differential. If you think it's dry eye, you have to do the tear osmolarity even before the slit lamp. Okay, because you touch the eye and cause tearing, and then if you put something on the eye, the entire tear osmolarity test will not be valid anymore. So you do that quite early. Then you do your slit lamp exam gently, no, so that you don't press on the meibomian glands. Then you look to examine the tear meniscus height. Okay, that's a very important clue. No? So if it's very low, okay, it's less than 0.3, okay, maybe you of a millimeter, then really that's very then every patient has significant aqueous deficiency without even have to do a Schermers. No, kung nakita mo very narrow, okay, ang tear meniscus height, most probably patient has aqueous deficiency, dry eye. Then you do look at tear breakup time. After the tear breakup time, you have to look for the pattern. Okay. In this lecture, we will not talk about the pattern. We will not have enough time. Just to let you know, and that's enough for a separate lecture. Then you look at the fluorescent staining pattern, okay, where it's mostly located. Again, in dry eye patient, usually it's on the exposed area, on the exposed inferior to mid to inferior, and on the exposed bulbar conjunctiva. Lissaman green also. You look staining on the exposed bulbar conjunctiva and look for the posterior lid margin. You might see the posterior lid PLM staining by Lissaman green. And at the very last, now, if you want to do a Schermers, then you do Schermers with anesthesia. Okay. So external examination, basically look for other things that can explain the findings of the patient or the symptoms of the patients, like atopic dermatitis, or these also risk factors also. Eyelid changes, now again, very common. That can cause very similar dry eye symptoms like ophthalmos, erythropion, lid margin irregularity, history of blepharoplasty causing lack of ophthalmos or poor opposition of the lid margin to the eyeball itself. Now, check for those. If they have proptosis, thyroid eye disease, more exposure, okay, and also cranial nerve function. If there is a decreased nerve, okay, so the feedback loop is deranged, so there is decreased tear production because of the lack of feedback. On slit lamp, okay, at the lashes, you look for trichiasis, this trichias crusting, okay, because you want to look for signs of blepharitis, or anterior and posterior, Staph, Seborrhea, MGD. Look at the conjunctiva, look for congestion, mucus trans discharge. If they have symblepharon keratinization, then they might have cicatrizing disease, they might have history of chemical burn or history of SJS, or they might have OCP. Again, all these can cause dry eye problems. Cornea, look for punctate keratopathies, filaments, frank epithelial erosions. Very rarely, only in the severely dry, wherein there's no treatment or where there's exposure, then they will develop corneal melt. Okay. In vascularization, keratinization, usually you see this again in those with chemical burns. You see this in SJS, where it's very severe ocular surface damage. So again, the caveat, avoid too much lid manipulation when doing slit lamp, because that will alter your tear breakup time. Okay. So you look for your tear meniscus height or your tear piercing height. They're the same thing, like with the slit lamp. Okay, usually 0.5 and above will be normal. 0.5, so 0.3 and below, okay, will be really have frank aqueous deficiency, dry eye. You need your KIP, you need your fluorescent stain, your Lissaman green stain, your tear streamer strips, and your BSS, your saline. Okay. So fluorescent stain, you should just put one drop, shake it off immediately, and tap it immediately to the lid margin. Okay, so you don't want your fluorescein to be too concentrated. Okay, you want it just dilute, but enough to stain the tear. Okay, you have to shake it off because you don't want to add additional volume to the tears. So very the proper way is just touch the lid margin gently, and then that's it. Because you want to stain so that it becomes visible. Okay, that's all you want. Don't paint it, okay, or drop a whole glob of dye, into the eye. Konti lang, okay. So touch it, that's it, okay, and then ask them to blink, and then you do your tear breakup time. Okay, you should cut off 5 seconds. Okay, anything above 5 most probably will be normal. Okay, more than 10 is always normal. Okay, and 5 and below will be abnormal. Then after that, they ask them to blink, of course. Remember, there's the new concept of tear breakup pattern, okay, as proposed by Professor Yoko and by the Asia Dry Eye Society. Okay, we'll just later run through it very, very quickly, but we will not delve too much time on it. Punctate keratopathy, okay, and then tear film debris, filaments now will show up, okay, when you stain them with your fluorescein and cobalt blue light. Okay, the next step is to stain the eye with lysamine. So lysamine in fluorescein, it should be dilute. It's the opposite for lysamine. In fluorescein, it will only work with dilute. If it's dilute, it will fluoresce. In lysamine green, it has to be very concentrated. If it's too light, it will not work. Okay, so you have to make sure you have it's very dark. Turn the solution into dark green. Okay, before you drop the solution into the eye. So the darker the lysamine green, the better. Okay, so you shake it. Okay, so that it would dissolve the dye pigments on the strip into the solution. Okay, and then you tap it into the lower inferior fornix without avoid touching, and ask the patient to blink. Okay, so basically, it will really stain mostly on the conjunctival side. So you can do an ocular staining. You may or you may not. Okay, when your own, as long as you put it in your notes, your findings. So this very severe staining. Okay, all across the entire palpebral fissure area. Okay, so this is, if you want to grade them, this is around grade 2 to 3 in the Oxford scale. This is grade 4 in the Oxford scale. And if it's denser than that, when it becomes confluent, okay, like one green touch, then it becomes a grade 5. So another important clue, especially if these are new cases without any previous medications, because once they start lubricant, or they get hold of a lubricant and start dropping, you won't see this. Okay, so in these new cases without treatment, try to look for the posterior lid margin stain, because you see this in patients with the dry eye, where there is decrease in the viscosity. Okay, so there's increased friction now between the posterior lid margin, okay, over the cornea. That's why this becomes raw. Okay, and lysamine green is a devitalized stain. It stains damaged tissue. So if you have damaged tissue there because of the rubbing on the eye with decreased lubricity, then that will stain. Okay. Okay. Then lastly, you may or may not do your Schermers. Okay. So if ever you do your Schermers, I always do it with anesthesia. Put anesthesia, wait for a minute, then dab it gently to remove the excess, and put the Schermer strip, and then close the eyes 5 minutes. If you do it closed eyes, do it closed eyes all the time. If you do it eyes open, do it eyes open all the time. Okay, there's no really right or wrong. Okay, because just do it the same way all the time. Okay, so that it becomes reproducible. Okay, so cut off is 10 is and below. Okay, will be you have to suspect dry eye. 5 and below is really dry. 5 to 10 could be equivocal, and more than 10 it's normal. Okay. So tear osmolarity now, if you do have it, cutoff value 312. Okay, so anything above that will be abnormal, or there is a difference between the eye also. Okay, that can also be a sign of abnormality. All these don't not in the, okay. Now this is just trying to show you the importance of your tear breakup time, or your short breakup time. So this is a large study done in Japan, wherein they look at office workers in the city of Osaka, and they notice that what correlates most with dry eye problem will be low tear butt. No, see, Schermers is everywhere. No, you can have very very high Schermers, but very very low tear breakup time. Okay, see that? Okay, so they put the cutoff at 5. Okay, at 5 seconds. No, because they all of these short abnormal patients are below 5 seconds. Okay, so this is the basis of why they use tear breakup time as an important criteria in the diagnosis of dry eye disease. And now here comes the pattern, okay, of that will tell you what is the component that is lacking. Because dry eye, the advocacy now is not to just give them any lubricant. No, you want to replace what is lacking in the eye, and you give a targeted therapy, that is customized to that particular eye. Okay, and you have to know what's lacking in that eye. No? So hindi pwedeng shotgun. Okay, so you want it very very targeted. Okay, so okay, so there's a whole physics on all of these. No, so just to let you know, first is the area break. Area break is basically when they open the eye, there is no tear film, and there is no complete tear film. No, madami ng dark area because there is no fluorescein there. Okay, so that is your area break. Why so? It's so dry. These are very severe aqueous tear deficient. So even when they blink, okay, there's not much tear there, enough tears to coat the surface of the cornea. So you get area break immediately. We call that an area break. It didn't form a tear film at all. Okay. So for line break, line break looks like this. Okay, so when they open the eye, then you see this breaks inferiorly, vertical breaks inferiorly over an area with punctate keratopathy. Okay, so this is due to also an aqueous deficiency, but milder form. In area break, it's severe. If you're like your rheumatoid arthritis patient with 0 Schermers, Steven Johnson's patients, those will have this kind of disease, this kind of pattern. Okay, this will be your regular dry eye patient. Now with low aqueous production, they will give you this line break. Okay, and spot break. Okay, this is due to poor wettability. So it doesn't coat the surface of the eye. The tear film. May tears naman sila, but however, it doesn't form a complete tear film. Once you open the eye, you see these round spots, dark spots. And that's why it's called a spot break. It's a severe form of tear film instability. So because of the problem is decreased wettability. It's a mucin problem. Okay, so line break is aqueous, area break is aqueous, spot break is mucin problem. Okay, dimple break is it's very similar to spot break, also a mucin problem, also due to poor wettability. It's just that the break occurs after opening of the eye, and then the center will slowly break. You call that a dimple break. Okay? So, nasa kitna. Ang spot, bilog-bilog. Okay? So, iba. So, the last is your random break. Okay? Random break is usually a normal. So, ibig sabihin, if the patient breaks in after 5 seconds, the tear film breaks after 5 seconds, most probably it's random break, because this is a normal finding. Okay? A tear film doesn't last forever. As long as you keep the eye open 5, 10 seconds, 15, some patients after 20 seconds, it will break. Okay, it will not stay there forever. So, but however, if you see a random break in less than 5 seconds, okay, wherein there's no pattern. Pag open, the tear film goes up, it stops, then it breaks. Okay, and you do it again, same timing, open, the tear film stops moving, and it breaks somewhere else. So it's a random break. It will not give you the same configuration, but it will always break after the cessation of the upward movement of your tear film. And this might be indicative if it's very short, in less than 5 seconds, it could be evaporative dry. Again, here the Asian Dry Eye Society separated evaporative for tear instability. Iba ang short tear breakup time or tear instability dry. Iba yung evaporative dry eye. Because when you talk evaporative dry eye, most probably the etiology is your MGD. If it's short breakup time, like spot break and dimple break, probably the problem is mucin deficiency. Okay, so the etiology is different. Okay. So that's why this is the classification. Okay, so if a dry eye patient, if you see a line break or area break, aqueous deficiency na yan, no? If you have a short breakup time and you see a spot or dimple break, automatically decreased wettability dry eye, that's a mucin problem. Okay, now if you see a random break and it occurs in less than 5 seconds, then probably it's a lipid, or it can also be a mucin. Okay, so very, very simple. Okay, at in one simple test, you can tell you what's lacking, what's underlying pathology, what's a probable cause, and you can give them a targeted therapy. Okay, so therefore you can classify them as aqueous deficient dry eye, increased evaporation dry eye, or your decreased wettability dry eye. Okay, so aqueous deficient, aqueous tear ang problema. Increased evaporation, lipid, and your secretory mucin. While your decreased wettability, it's your membrane-bound mucin and your corneal epithelial cell that might have problems. Okay, so that's how you target your treatment. And that's your tear film-oriented therapy. Okay, so we're in based on what's lacking. Now you give the treatment, okay, to supplement or to improve the production or to normalize those components that are abnormal. Okay, now the really severe ones are those with Sjogren's syndromes. Now, these are those with they might be Sjogren's itself or your secondary Sjogren. Okay, secondary Sjogren's are those with rheumatoid arthritis, SLE, etc. But on Sjogren's, it's primary. They don't have all of those. It's just they have very dry eyes, very dry mouth. Okay, low Schermers, the ocular surface will stain with fluorescein lisamine. Okay, the gold standard for diagnosis is salivary gland biopsy by ABC lymphocytic infiltration. Okay, so you can also do some tests. You can give them a request online. Okay, they can go to the lab, they look for SSA or for SSB antibody, and they're positive for this, and you have a diagnosis of Sjogren's syndrome. Okay, so this for secondary Sjogren's, so these are all the things, the autoimmune diseases that you look for. Of course, the most common is still your rheumatoid arthritis and SLE. So those at least very, very at the minimum, you ask about those two. Okay, so treatment. Okay, so there's conventional treatment of dry eye. Okay, so tear replacement, it's still a part of it. Okay, tear preservation. Okay, if you want to preserve vacation, you can cauterize the opening of the punctum, okay, or decrease the size of the palpebral fissure by doing a persorrhaphy. Okay, non-surgical punctal plugs, moisture glass or tires, bandage contact lens. So dati, ganito lang. We only have these options. Okay. But the current treatment now we now know more about the dry eye conditions. So now you have your P2Y2 agonist like your diquafosol that increases mucin production, okay, and decrease epithelial aqueous secretion, okay. So that can actually improve, okay, the components that are abnormal. Okay. We all know that dry eye is an inflammatory problem, so therefore you treat them with steroids. Now you have an option of dexamethasone or loteprednol, okay, or even prednisolone. Okay, most of the time nowadays, if you cannot follow them up, okay, to check the eye pressure, maybe just loteprednol. Okay, that is the least chance of causing increase in IOP. Okay, then for cyclosporin, you want to give them long term, especially in severe cases. I don't give cyclosporin for all dry eye patients, only for severe dry eye, especially with punctate staining. So this will the Sjogren's syndrome, secondary Sjogren's, those with really bad inflammatory problems. So you have your eye curves and your restasis. Okay, and autologous serum, in some cases, only when other treatment might not work. Okay, you might have to do autologous serum, but again, it's very inconvenient. Okay, the shelf life is very, very short. Okay, you can give them omega-3 essential fatty acids, okay, just as a supplement, okay, it's not a cure, okay, okay. And then if you have other findings, then you have to treat them. Don't forget, again, they go hand in hand. No? So some dry eye patients will also blepharitis or MGD. So all of these conditions have to be treated, okay, adequately. So basically, what do you have to do? No, you have to establish the type and severity of the dry eye. No, it cannot be just pure simply dry eye disease period. No, you have to type: is it aqueous deficiency, evaporative? Is it tear instability? Is it a mixed type? No, is it mild? Is it situational, or it's just occasional lang? Okay, is it mild, moderate, or severe? No? So you treat other problems. Steroids are just given for 2 to 4 weeks. Okay, enough na yan. No? You don't have to give anything longer. Topical Robical is still a mainstay. You have to choose between you want to give tears or gels or viscous fluids, preservative, non-preserved. So if you're going to give it more than 6 times a day or more 8 times a day, then it becomes non-preserved. It's mostly rule of thumb, severe cases, they need more than automatically non-preserved as much as possible. P2Y2 agonist can now become a first line. It can also be can also end up as a monotherapy, no? Because it improves the mucin. However, it's not long lasting. No, it have to be given constantly. Okay, the effect is not a cure. Okay, cyclosporin, if you want to give it more than 3 months, no, because the effect starts at around 3 months. Okay, occlusion as needed when there's no more inflammation. On follow-up, you always monitor the tear breakup time in the findings in the staining patterns, okay? And don't forget to control risk factors like medications has to be changed or that to be stopped, that to be discontinued. And very important now is environmental medication modification and patient education, because a lot of times it's just really bad habits, okay? So if you modify this, if you change this, if the patient understands their condition, what's causing it, then probably you could, not just like this today. No, I have a patient who, because of the lockdown, she watches YouTube, no, hours and hours, no, and then she will complain the blurring of vision and all that, no, okay, without resting. Okay, so just explain to her, okay, that you have to do this. You want to watch, we're not saying you cannot watch. No, you just have to do frequent breaks, okay, so that they understand. Okay. All right. Okay, so this is a simple dry eye protocol. Not just to show you lang that there is your situational dry eye is wherein symptoms lang and all the tests normal. Mild dry eye is with symptoms, or you have an abnormal tear breakup time or an abnormal Schermers. Okay, in moderate dry eye, you have all of the above symptoms, abnormal tear breakup time or Schermers. Then you have staining on the conjunctiva, that becomes moderate. Now, if you have staining on the cornea with filaments and all that, that becomes severe. Okay, and in the severe cases, now you might have to put bandage contact lenses if the cornea is really totally okay with dense staining. Then you have to hasten the healing now by putting a bandage contact lens. Okay, now when you put the bandage contact lens, now don't forget to give your topical antibiotics. Make sure it's not preferably, it should be preservative free. Okay, because you don't want the eye to be soaked with preservatives. Okay, the cornea to be soaked with preservative, which is in your contact, is soaked up by your contact lens. Now don't want that. Okay, so there. Okay, in situation you don't give anything, you just advise the patient and then change their lifestyle, remove their bad habits and give them preserved tears. Okay, here when they have signs already, steroids for a month. And moderate dry eye, no, then you want to do more now. Okay, you can start now cyclosporin in these cases. Now here you have to give steroids and cyclosporin, no, because and do all that. No? So it's a stepwise approach. No, that's why it's very important to know the type and the severity. Okay, and for the last part of today's talk, okay, will be your herpes zoster. Okay, decided to put it here because again, this might is something that you can actually diagnose really remotely, no? Because the signs are very, very obvious. Okay, and it's common. Okay, so if it's stressful time now, no, the patients might have recurrence of herpes zoster. So 1 of 5 will have zoster reactivation in his lifetime. Okay, and 10 to 25% now will have herpes zoster ophthalmicus. Okay, so one fourth of patients with zoster, okay, will have, it will be an ophthalmic branch. Okay, and those with herpes zoster ophthalmicus, more than one half, no, will have ocular involvement. Okay, so when you treat, okay, you should think that you should just earn and there is an ocular or ocular service involvement. Okay, it's common. So they send you a picture. I mean, of course, the history. Now there's pain, there's scalp, there's discomfort. At the start, it can be very, very, very subtle. No? Masakit pag nakaipuan o nahanginan, masakit, sensitivity, bigla-bigla. No lesions pa. Usually they feel something na. No? So if it's one-sided, with no lesions, put at the back of your mind, maybe it's herpes zoster. In the next few days, now then the vesicles will come out. Now, once the vesicles comes out, then you're absolutely sure this is herpes zoster ophthalmicus because nothing else will present as such. Okay, so again, an elderly patient complaining of pain on one-sided, okay, of acute onset, okay, with no trauma, okay, suddenly parang masakit. No? It's very sensitive. Elderly, maybe it is herpes zoster. Of course, children also can have herpes zoster, but not as frequent. Okay, so again, it has 2 peaks, now in the children and then in the elderly. So the lesions are pathognomonic. Okay, you have the vesicle not crossing the midline following the dermatomal distribution of your ophthalmic branch of your cranial nerve 5. Now, here, lots of complications. No? Kung pwede, they have to be seen. Okay, they have this one condition, easy diagnosed by teleophthalmology, but they have lots of complication. So you have to make them come in to get all of this check out if they have all these things, these conditions, the conjunctiva, sclera, on the cornea, okay, in the anterior chamber, and the retina, eye, and all that. Okay, well, you cannot see this when the patient take a picture, no? Okay, so if they do come in, you might expect some pseudodendrite, especially if they have blurring of vision, foreign body sensation, no? Well, sometimes it's so painful, no? Everything is so mixed up, no? The patient cannot tell which is which. Okay, and then there's lid swelling, it's the eyes closed, no? They don't really, no, it's hard for them to tell. Okay, so they really have to be examined, stain it. It's raised, it's quite irregular. It's not the true dendrite as you will see in herpes simplex. Okay, so you call this a pseudodendrite. Okay, like so. Okay, it's not a true dendrite. In some cases, again with blurring of vision, we'll come up with nummular keratitis, no, an interstitial keratitis in the center. Oops, nabaliktad tong dalawang picture. Anyway, so this is just to follow the other plaque, the epithelial plaques. Okay, so the dendrite, okay, these are not real dendrites. Okay, so these are on top. No? That's why they're raised. They stain, but they're raised. Okay, so this is a sclerotic sculpture. You can see it, but if you stain them, it's easier to see. Okay, so then if they have keratouveitis, no, like cells and flare, hypopyon, this patient also had an epithelial erosion on the cornea. So these are this is several weeks out now, no, with a synechia, but with still focal scleritis here, no, so they can occur together. It is like iritis and your scleritis, okay, or a neurotrophic ulcer, like so. In the more chronic cases, no, when they have unresolved interstitial keratitis and they have corneal vascularization, they might develop lipid keratopathy. Okay, these are late now. Okay, not during the acute. You see sectoral iris atrophy that will tell you patient might have had herpes zoster. Okay, in the past, no, and this is a focal scleritis, spastic entropion because of the affectations of the nerve. Okay, this is a patient within this all the way down to the apex. No, patients have cranial nerve 3 palsy. Okay, so there is loss of abduction and their eye is dilated and there is ptosis. The pupil is dilated and there is ptosis, abduction. So in chronic cases, no, they would, as they heal, no, they can cause hypopigmentation and scarring. And the retina, especially if they have really decrease in drop in vision, okay, then they have to be seen, no? They can have acute retinal necrosis, no, in the immune deficient patient, no, they might present with your PORN, no, your progressive outer retinal necrosis. So, first outset, no, they cannot come in for whatever reason. Okay, first, if you see the lesions that is typical of a zoster, then you give them oral. Okay, treatment. Actually, the drug of choice is valacyclovir. Okay, at 1 gram 3 times a day. Okay, for a child, maybe 500. 3 times for an adult, it's 1 gram 3 times a day for 7 to 10 days. Okay, and should be started in 72 hours from onset. Okay, so this is a mainstay. Okay, you have to start this early to prevent the neuralgia, because the problem later on is the neuralgia. So antiviral treatment is very important. Okay, clean the lesions with soap and water. Okay, or just povidone iodine cleanser. Then apply antibiotic steroid skin ointment on the skin lesions. If they're very near the eye or the lid, on the lid margin, then I will give them preparations for the eye. But if it's on the skin, just give them preparations for the skin. If they have mucus plaques, then you have to debris, okay, with a stair cotton applicator. If they come in with nummular keratitis, scleritis, or iritis, then you have to give atropine, you have to give encycloplegic agents and steroids 4 to 6 times a day until the conditions resolves. Okay, then cover them with topical antibiotics. Okay, and again, do not be afraid to give steroids in patients with herpes zoster ophthalmicus. Unlike patients with herpes simplex epithelial keratitis, where in steroids is a no-no, in herpes zoster it's all right. Okay, you can give that, and you must not to prevent all these complications. Especially if you cannot see them, and then you are not sure, it's all right to give steroids. At least you could prevent, if they do have complications like iritis, at least you cover them with topical steroids. Pain control is important. Okay, steroids, oral systemic steroids may be given. Okay, if they have ocular surface problems, you can give your lubricants and gels. Okay, just to support them. A supportive management. Okay, you have chronic problems. So if they have a non-healing defect because become neurotrophic, then you might have to put them on a bandage contact lens, okay? Or sometimes you have to do a tarsorrhaphy if there's exposure, okay? You can try contact lens first. If it doesn't work, then sometimes you have to do a tarsorrhaphy. So if they have corneal thinning, then probably you have to do again, especially if there is if there is irregularity in the surface of the cornea, apply a bandage contact lens to keep that area moist. Okay, if they have lid changes, then refer to the PL for lid surgery. Okay, there. So, ito tama. So we have 15 more minutes to for the open forum for any discussion, for any things to clarify. Okay, so this ends the part 1 of my talk.